Okay, I think we'll get started. We've got a good number in this afternoon. So again, thank you for joining us. For those of you who do not know me, my name is Norma Tomlin. I'm a proud RPN working as the Director of Professional Practice here at WeRPN. Today, I'm honored to be facilitating this Nursing Week session, and we're showcasing RPN leadership, CHEO's Clinical Informatics Champion Program. We'll start off with the land acknowledgement. We would like to begin this session by acknowledging that WeRPN is located on the traditional lands of the Anishinaabe peoples. With this, we respect the long-standing relationship that Indigenous nations have to this land, as they are the original caretakers. We acknowledge historical and ongoing injustice that First Nations, Inuit, and Métis people endured in Canada, and we accept responsibility as a professional organization to contribute towards revealing and correcting misinformation, as well as renewing respectful relationships in Indigenous communities through our teaching, research, care provision, and community service. I would also like to acknowledge today all the Ontario Registered Practical Nurses across the care continuum, and I would like to extend my heartfelt thank you to each and every one of you for all that you have done and are doing to care for Ontario patients, residents, and clients as you continue to go above and beyond in your commitment to care. Happy Nursing Week to each and every one of you. As virtual attendees, you can watch the presentation live and engage throughout the chat and the Q&A function. Please let us know, as I said, where you are coming from. And I've seen some really great locations: Hamilton, Ancaster, Ottawa, Toronto. We have RPNs and nurses from all over the province watching this afternoon. So thank you for joining us. It's a pleasure to have each and every one of you here. If you require technical support, please contact ppractice at werpn.com or via telephone 905-602-4664, extension 228, and ITSO will assist you with any of your technical needs. At the end of today's session, we will be announcing a winner of the session, our door prize, so to speak. And so please note, you must be here to if your name is drawn at the end of the session for your prize, or we'll have to redraw another name. So you want to stick around to see if you've won our door prize. Now it gives me great pleasure to really introduce our stars of this afternoon in this session. I first want to introduce our speakers, Allison Gerard. She's the Director of Nursing Practice and Chief Nursing Informatics Officer. She is a nurse and health administrator dedicated to professional practice, clinical operations, and ensuring the delivery of high-quality healthcare service. She has almost 20 years experience in the healthcare field, including professional practice and education, clinical informatics, acute care operations, quality improvement and patient safety, nursing policy, project management, patient relations, administration, and frontline clinical care. Laura Strachan our next speaker joined the CHEO, the Children's Hospital of Eastern Ontario, in 2001 as an RPN, having recently graduated from Georgian College PM program in 2000. She also holds a degree in Recreation and Leisure Studies, BRLS, from Brock University. Her 24-year career at CHEO has been spent loving and caring for babies and toddlers on the inpatient medical unit. Laura has been involved in nursing informatics at CHEO as a medical unit, as a super unit in 2017 when CHEO launched EPIC. As the nurse lead developing virtual rounds during COVID to keep families involved despite the restrictions, and most recently in clinical informatics champion role. And next we have Megan Salone. Megan is a clinical manager of the inpatient medical unit at CHEO. She's duly registered RPN and RN with experience in acute care management, quality improvement, and regulatory governance. She has centered her career on improving access and outcomes for patients with a focus on supporting healthcare providers to deliver innovative care. And with that, I will be handing it over to our speakers this afternoon to present on their champion program of informatics. I will stop sharing.
Thank you so much for that introduction. Can you see our slides okay?
I can see the slides, yes.
Fantastic. So Megan, Laura, and I are excited to be here today to showcase RPN leadership through our new Clinical Informatics Champion program. And there you go. And so for today, we'll go over a little bit about the Clinical Informatics Champions program. So what that is, the goals of the program. We'll describe some of the outcomes that we've seen in the first year of having this program launched. And then we'll hand it over to Laura to give a detailed overview of her Clinical Informatics Champion project and the work that she's led in this role. We'll hear her reflections as a leader and on her growth and experiences that she's learned within the program. And then finally, we'll discuss the collaborative environment fostered by the program and the challenges and successes at the unit level. So first, CHEO is more than a hospital, but we also want to acknowledge that we are joining this webinar today from Ottawa, which is on the Algonquin-Anishinaabe territory, and we honor the contributions, past, present, and future of this land, and are honored to be here today presenting to you all. So CHEO is more than a hospital. So although we are an acute care facility, we are so much more than that as well. So we are a children's treatment center, a child youth mental health agency, rehab service, research institute, training and education session. We have home care underneath our umbrella as well, and much, much more. And really, we work together as nurses and nurse leaders across our hospital and our health system to provide the best life for every child and youth. So again, that's our vision, best life for every child and youth. And you'll see that tied through the work that we've done with our Clinical Informatics Champions program of really having nurses driving innovation and improvements for children, youth, and families. And so a little bit, I won't spend too much time, but just a little bit of a background on the program and where it's come from. We at our hospital here at CHEO launched a new strategy last year for caring and growing to help children and youth reach their best lives. And we also at the same time worked with our Nursing Advisory Council to implement the National Nursing Retention Toolkit. Likely many on this call are familiar with that toolkit that was launched across Canada in late 2023. And really, as the nursing community here, worked through the different pillars of nursing retention and what it meant at our organization to have professionally supported and fulfilled nurses. And so one of those branches that you see in the strategy toolkit here on the right is around professional development and mentorship and inspired leadership. And so tying that, those pillars of the framework and the toolkit with our own strategy for developing and leveraging clinical expertise through our Bright Future strategy and through Strong Team to attract, support, and retain the very best staff, we engaged our nurses on what was meaningful and important to them. And one thing that we heard loud and clear through that professional development and mentorship branch was around having opportunities for mid to late career nurses, both for professional development and for leadership. And so thus came the idea of a Clinical Informatics Champion program, which we launched last year. So a little bit about the program. This was, again, in response to nursing retention and really wanted to do two key things. One, we knew that we really had some opportunities within clinical informatics at our organization, and we knew that those working at the front line had incredible optimization ideas and opportunities for how we could improve our interactions with our electronic health record in patients and families. And so we really wanted to advance that footprint of nursing informatics across our hospital by engaging those frontline nurses in Epic technology design, implementation, dissemination, and optimization. And we also wanted to create formal professional development and leadership opportunities for our nurses as a retention and engagement strategy. And so together, we were able to bring on 6 clinical informatics champions who dedicated 0.2 of their roles or their FTEs to this work. We really base this on principles that come from the CLASS Collaborative, which does research on electronic health record satisfaction, and know that there are 3 pillars of success as it pertains to satisfaction for users. One of those is education, governance, and so having a shared governance, which we're all as nurses familiar with, and EHR personalization. So really looking at some of these foundational pillars as well as we built up the program to help all of our nurses become more satisfied with the EHR, recognizing how much time on a shift is spent in there and documenting. And so what are these informatics champions doing in their 0.2 FTE? So lots, and it's been really exciting to see this program bloom over the last year. So primarily our champions are acting as liaisons between our informatics and clinical teams. So they're bringing forward build fixes within Epic. They have optimization ideas and disseminating key plans. They participated in nurse efficiency training through Epic. So Epic is the electronic health record that we use. And so they participated in efficiency training on a variety of topics and then went out and shared those learnings with nurses at the elbow. They also participated in lean management yellow belt training. So lean management is the management philosophy that we use here at CHEO for continuous improvement, and provided our champions with professional development training on how to roll out a project and really understand the project cycle and quality improvement tools that are available. They disseminated and championed Epic upgrades and details at the elbow. So most of their championship time was spent out on the clinical units, engaging with staff, disseminating monthly messages, showing people key tips and tricks on how they could be more efficient with the system. And then probably most exciting is they also, through close mentorship with a formal mentor, identified and led an Epic optimization project of their choice to identify and address a clinical gap in their area. And together as a community of champions, they also participated in workshops, mentorship, and collaboration over the course of the year as well. From an outcomes perspective, I'll share just a couple key things, and we're very grateful to Carolyn Yee, who is a Master's of Nursing student who formally evaluated the program for us this year. But one of our key monthly messages was around using flowsheet macros. So this is an efficiency tool within Epic, our electronic health record system, to save clicks. And as you can see, last summer, nurses were saving about 53,000 clicks using macros. And our informatics champions like Laura spent much of the fall showing nurses how to create macros, how to apply them, and how to use them, and able to reach up to over 90,000 clicks saved with macros. So really helping nurses get back to being able to provide care at the bedside and being away from the computers. And so just to show you in a different way what this equates to and what this means for clinical teams is the amount of macros that were saved, or sorry, the amount of clicks that were saved by introducing macros equated to 5 days of time saved for nurses. So 5 days or 10, 12-hour shifts around the clock, being able to return back and provide care. So really meaningful and important impact. And then going back to one of our primary outcomes of the program was really around retention and helping our mid to late career nurses have additional opportunities. We did a qualitative review with our informatics champions and the impacts around their retention. So although a small group, really feeling that it has an impact on burnout, that it offered an opportunity for them to step away from the bedside and lead something in a new and exciting way. This, of course, opened the doors for different career discussions, for stepping out of their comfort zones, and looking now to, what's next and additional opportunities as informatics champions. And so I mentioned that the clinical informatics champions each participated in an optimization project of their choice. And I know that's why you're all here today, to hear from Laura on her project and the work that she led over the last year as an informatics champion, but wanted to show you here the other projects that were worked on as well. And so for here today, you'll hear from Laura, who led the NG-Tube Education Completion Optimization Project, which you'll hear has great value and impact to our patients and our families. So I'm honored to pass it over to Laura, and so she can share the work that she's done over the last year.
Thank you. Happy Nurses Week to everybody. Thanks for coming and visiting with us. As you heard, my name is Laura. And like most nurses that stay in one position for 20 to 25 years, inevitably a sense of routine starts to creep in. My job for the last 24 years, as you heard little snippets of it, was on a really busy acute care medical floor at CHEO in Ottawa. And wow, have I seen changes in my role as an RPN on the floor. When I was first hired, the RPNs could do vital signs, give the babies and children baths, give some oral medications, manage a basic IV infusion, as long as there was no KCl in it, in the line. We didn't dare touch central lines, monitor chest tubes, suction at trach, or even help with CVL dressings when the RNs were doing them. Fast forwarding 24 years, and a routine day-to-day for me might have me caring for a child with a tracheostomy, titrating high-flow nasal cannulas and BiPAP machines, administering narcotics and TPN via PICC line, doing my blood work, taking children with chest tubes off the unit for x-rays, and managing insulin and ketamine infusions in our new intermediate care unit. So the role has changed so much, but yet there's still a little piece where there was fewer opportunities for RPNs to do things outside of the bedside nursing. So when the clinical informatics position came available, I was a little bit nervous to apply, to be honest, but my frustrations with one area within Epic and my charting that I had to do on a daily basis, it needed optimizing. And so my frustration was greater than the sum of my fears. So I went ahead for it, and I ultimately was hired into this one-year position, a term, along with 5 of my RN peers as an informatics champion. And to be quite honest with you, when I was offered the job that I didn't think I would get, I thought, oh no, what did I get myself into? So before I get to the, oh no, what did I get myself into, I'm just going to tell you a little bit about my project. And at the end, then I'll circle back to that, oh no, what did I get myself into piece. So as you heard, my project was based on a checklist that we have within Epic that needs to be completed when children are going home with NG tubes. It's for the parent or the caregiver to ensure that they have all the skills and all the knowledge to go home safely with their child and know how to deal with every possibility that might come up with that NG tube. Because here in Ottawa, we do expect the families to put the NG tubes in at home if they do come out. So there's a lot of training, a lot of angst for some of the families. So the problem that I encountered, and which was frustrating enough for me to go outside the box and outside of my comfort zone and apply for this position, was that the patients at CHEO were being discharged home with NG tubes with incomplete NG learning checklists. And this was placing our patients at physical and emotional risk, as well as the healthcare providers. We were also at risk for some liability if anything ever happened. And we couldn't show any evidence that we had actually done the proper training for the families. So, which brings me to, I wondered if really, is it a problem, or was it just me feeling a bit frustrated? Like, were the numbers really as low as I thought? So within my goal statement, I did a little bit of an audit. So of the patients discharged with an NG tube from CHEO between 2022 and 2024, only 4% of these children had fully completed caregiver teaching checklists. So my goal became between July of this year, of 2025, and December of 2025, my goal is to get to 75% of patients discharged with an NG tube to have a completed education checklist. And I'll evidence that by doing some chart reviews early into 2026. So I took a three-pronged approach to getting the information I needed, and do my measurements. First of all, I needed to survey the nurses to find out, why are we not using this tool? I had my own thoughts. I felt that it didn't meet our needs. I really actually thought I was going to be recreating a new tool when I started, because I felt the tool didn't work. But putting my own biases aside, I surveyed the nurses at CHEO. I audited some charts, and I also consulted some of the other pediatric hospitals to compare their practices. So I started off with an assessment of nursing knowledge, and I sent a survey to 221 inpatient nurses at Children's Hospital. My goal was to find out, what did we know about the education checklist and how it's being used. Okay. So we'll start off with a few of the survey results. And so what I did, it's okay. First question I asked them was, are you aware that there's a teaching checklist in the education activity in EPIC to fill out when your children have NG tubes and they're going home? And only 86% of our nurses actually knew there was a checklist. So already we're falling a little bit behind. Okay. And then the next question I asked them was, I asked them if they knew how to find it within EPIC and add it into the patient chart. And as you can see, only 66% knew how to do that. So when we're looking at that already, I'm already missing a third of all the people. They don't even know how to add the thing into the chart. Okay, so just wait. So why aren't we using it? It'll do itself. It's okay. So many reasons why we're not actually using the checklist, according to the nurses. Everything from, they don't know how to add it to the chart, there's not enough detail, it's too time consuming, click it again, please. It's hard to pick up where someone else left off in charting. All of these reasons were reasons that were brought to the table. Some people, some of our novice nurses, they didn't feel comfortable enough in their own skills to be able to sign off for somebody else's skills. They just didn't have that comfort level and in the teaching. Some of it comes down to time, all those things that we know, are pressures on the bedside nurse. Okay. So after I did this survey and I was kind of getting a feel for where things are at, I wanted to know the actual numbers. So my colleagues in the IS department, they pulled a report that identified every patient across the Children's Hospital in the previous 2 years that had an NG tube showing on their discharge paperwork when they were discharged from the hospital. So they pulled over 700 patients in this report, so that in that 2-year period, I had to audit about 300 charts to find 100 patients who actually met all the inclusion criteria. There was a variety of reasons why it might show there was an NG tube on their discharge paperwork, but they really didn't go home. So audited about 300 charts to find 100 patients who actually did go home with an NG tube for the very first time. And the numbers were shocking. Okay. So it's okay. So when you look at the numbers, I'm going to start off in the blue section. And if you look at it, a full 29% of all the charts that they did, there was not even a checklist added into the chart. So these children went home with absolutely no documentation that any teaching was done. Moving on to the green section, a little bit better, 41% actually had the checklist in their chart, but there wasn't anything written on the checklist. So we got part way, but it's showing where some of the barriers were. Like they could find it, they could input it into the chart, but then couldn't get it to work how they needed it to. 26% had it partially filled out, and then back to that little sad number of 4% only had their checklist fully completed. So that's a lot of gaps in our charting. It's a lot, as I mentioned earlier, it leaves a lot of people open to some liability, both as professionals, as healthcare professionals, as well as the children. If their families didn't get the proper learning, they might be at risk of their family not knowing how to care for that tube properly. So not ideal at all. We needed to fix these numbers. Okay. And then I took a quick look at what some of the other pediatric facilities in Canada are doing. And I spoke primarily with three of them, that they also use EPIC as their charting platform. And all were documenting very low completion rates on the education checklist. So it wasn't a CHEO specific problem. It was something wasn't working with this checklist and the frontline users. Two of the hospitals out of the three actually abandoned using the checklist altogether in their day-to-day practice, and they'd gone back to a paper checklist the nurses could fill out at the bedside, and when the patient was discharged, they would scan that back into the chart. So here we have this tool no one's using, and they've gone back to paper, which seemed a little backwards to me, that we've gone backwards. And then one of the hospitals actually was just kind of pretending they didn't really have a problem, and they just didn't address it at this point. It wasn't a priority for them at this time. And all three are very interested to hear what I had to say at the end of my study. They all want to know how we are going to address it. But what I did find interesting, and it was at the beginning, it felt very separate to what I was actually trying to achieve, but all of those pediatric facilities, they'd all instituted NG teaching classes for caregivers away from the bedside and away from the frontline nurse that's doing, might have 3 or 4 patients that are also trying to do teaching for the NGs. So they've brought it into an environment that was safe for the families, quiet, free of distractions, with all the appropriate resources. And they were finding that this helps ensure the completion of the learning. It enables the person teaching to start that checklist, get it into the chart. It minimizes the caregiver stress, and it also improves the bedside nurse's workload in that she just has to update and reinforce ideas as opposed to teaching from scratch. Okay, just once, yeah. So looking at all this data, I took a peek and I finally came through with 4 root causes of why this was not getting done. First one being knowledge deficit. The second one is functionality limitations of our electronic health record. Third one, barriers to learning completion. And the fourth pillar was completion accountability. So I'm going to start with the big one, and it was indeed the biggest piece of why we weren't having it filled out, was a nursing knowledge deficit. You saw so many reasons on the little slide a few ago. Where is the checklist? How to insert it? We can't make it work. It's not detailed enough. It takes too long. They were really struggling with everything. The language that was used, that's used within the document itself, was even problematic. They used terms like file, and then the next button was file and resolve, and people didn't know what those meant, and it was becoming a problem. So instead of taking a couple of hours, which is literally what it took me to understand this flow sheet well, it took me 2.5 hours of just playing in it. They just don't have time, so it's not getting done. If I move on to the electronic health functionality limitations, so there were sort of 4 areas that I thought I could tweak the flow sheet to make it a little bit easier for the nurses. One was a better way of identifying who the caregiver is that's doing the learning. Within the flow sheet, there's an option for teaching caregiver 1 and caregiver 2, but no real place to put that caregiver 1 was mom or Nancy or whoever, and caregiver 2 was the dad. So we needed a way to identify the caregivers easier, so the nurses didn't have to spend time figuring out who we were talking about. I also wanted to look at a way of having the chart, or the flow sheet, automatically inserted into patient charts for the patients that needed NG teaching. So that it took away that piece of the nurse had to find it and then pull it into the chart for the patient. I needed to look at a way of identifying the symbols that were used in the chart so that the nurses could understand them. Unfortunately, within Epic, there was no easy place to see a nice little legend of what the symbols they used in the charting in this flow sheet and what they meant. So nobody knew what the circles meant, and nobody knew what a green check mark meant versus a white check mark. So that was a problem. And also some of the language that was used in the flow sheet was problematic. So I did have a little bit of a success there, and I'll talk about that in a little bit. Barriers to completion. We were finding that the nurse's own experience was a big barrier. Novice nurse versus senior nurse. Sometimes I don't like those terms, but it really made sense. If someone has never put in an NG tube and has just started their career and isn't even confident with, do I flush with 3 mils or do I flush with 5 mils for an 8 French tube? It made a difference in their comfort level of doing the teaching, and they were a little bit nervous to sign off someone else's teaching when they weren't 100% sure of their own skills. the environment that we were trying to do the teaching in was less than ideal. Often in a 3-patient room, the nurse might be caring for a patient with a tracheotomy and also trying to teach another family how to do NG care. And of course, I might have to interrupt my NG teaching 3 or 4 times to go and take care of the airway in bed 1. Obviously, that the airway has to take priority. You come back and now we've wasted time. We've lost our momentum in the teaching. The baby's now crying because he's hungry because his feed's late, and mom still has to put the NG tube in. Family's upset. Everyone. It's a poor learning environment. Some of it came down to parental readiness. As nurses, we weren't maybe letting the families learn early enough, and we were trying to kind of jam a lot of the information in right at the end. It was very overwhelming for the families who were trying to think of taking their baby home with an NG tube, to be trying to learn it all quickly. And then, of course, nursing time constraints with the full patient load, trying to do the teaching on top of that. It was a little bit hit and miss what got taught. And then finally, there was nobody at the end of the day in completion accountability. Nobody was accountable to make sure that that form got filled out before the patient went home. So what we were finding was, historically, when we had a little nice paper checklist at the bedside, before our community discharge team would give all the supplies to the families and get them all set up, they required us to have a completed form. When we transferred over to electronic charting, we lost that. Somewhere in the translation, nobody was responsible anymore. So that was another piece of it. So those are sort of the 4 root causes of where we kind of ran into trouble in getting this done. Just quickly, we're now in the process, coming to the end of my term, we're in the process of kind of implementing some of these things. We've done a lot of brainstorming as a group. So some are in progress, some are still a little bit on the wish list because they take a little bit longer. So with the nursing knowledge deficit, it's probably the biggest one for us to tackle, but it's also one that we can do lots of things quickly and start making a difference right away. So we use huddles at CHEO to meet with our coworkers that happen to be working on a Tuesday afternoon, 15 minutes, that's it. So we're using our huddles to do quick teaching sessions with all the nurses. Our clinical resource nurses, they have a pile of tricks where if there's a little bit of downtime, they have all these little 5-minute sessions that they can just pull out. It might be central line dressings or something along those lines. We've now added the NG teaching checklist into those 5-minute sessions. Of course, we put them into our unit newsletters in the morning when we do a report on all the children in the morning. Our care facilitators that are doing the report, they're identifying patients that really that are going home with NGs in the near future, and they'll mention to the nurse, okay, Laura, don't forget, the patient ABC is going home next week. Can you just make sure that we've got all our documentation done on the teaching checklist? We've put up some posters around the unit, kind of identifying the expectation now that this needs to get done. It's not really an option. We have to do it as a group. We put the staggering statistic of only 4% of children on it, and that seems to be catching people's attention, that only 4% of kids are going home with the right safety documentation. And of course, our educators are helping to target teach some nurses. So those are kind of what we're doing right away in-house, right on the unit level. We've kind of focused on our own unit right now because we have a very big medicine unit, and then we'll see where things go after we've achieved some success. So in the section of inconsistencies impacting learning, this is where perhaps the biggest project might come about. And it's not done yet because, of course, now we need committees, and committees take time getting everyone together. But our goal is to create an NG teaching class for parents, take the teaching away from the bedside, and we'll have one consistent nurse or educator or whoever is hired into that position to run regular NG teaching classes for the families. They'll be done in a classroom, perhaps in a sim lab, and there'll be a consistent instructor that is knowledgeable on the NG insertion. And what this will do is, one, it'll help eliminate all the outside distractions for both the nurse and the parent. So they're both going to have a better experience with this without all the extra noise. We're going to respect the bedside nurse workload. As everyone knows, it's just do more with less now, and we have more patients and they're more acute. So now we have to look at what can we do to manage those workloads. And so this is something we can do. Take all that initial teaching, put it into a classroom for an hour or two, whatever it takes. Use a translator if we need to with our families, doing the initial learning. Then the bedside nurse can do the reinforcing. And all the initial charting can all be set up by the instructor of the class, and all filled out, and notes maybe mom was struggling a little bit with this concept, or so maybe you can focus a little bit more on that, all within this teaching document. Then the bedside nurse merely has to update it as they see the parents become more proficient in the skills. And all of us together should hopefully reduce some parental anxiety being in a safe place. Currently, we're asking parents to put NG tubes into their baby for the very first time. And myself as a nurse, I was given the opportunity as a healthcare provider to put it into a mannequin first. And I was still scared doing my first insertion, and it wasn't my baby. So, we can only imagine how awful this must be for them and so hard for some of them. So we're going to use the mannequins and let them learn and ask all their questions when their baby's not crying for hunger in front of them. Okay. And then down to the last two root causes, the electronic health record functionality limitations, big word. We talked about earlier, consistent identifying for the caregiver 1 and 2. Unfortunately, this isn't something that was going to be able to be fixed within EPIC, in talking to my IS colleagues, because it's an area that we can't modify in EPIC. Now, as a group, we've decided on a way to sort of a workaround of that. So in a different place within our EPIC charting, we're going to make a comment for NG learning. Caregiver 1 is dad, caregiver 2 is the mother. So it didn't get put right where we wanted it, but we're coming up with a sort of a workaround to make it work and make it easier for the nurses. There was an idea, a request, that when the physician orders, currently they order, please start NG teaching with family. When that order goes into the patient's chart, we want it to trigger automatically to insert the whole NG teaching checklist right into the education section. That was a win for us. It isn't there yet, but on one of the future upgrades, that is going to happen. So then the nurse doesn't have to find it, insert it. It's just going to get done. It'll be a little reminder that we need to do it. There was a page about learner readiness within our EPIC flow sheet, and it was a little awkward. We'd asked for some changes to improve the learner readiness page, which unfortunately we can't make changes to that. And then the last request I had made was to change a screen. So anytime a nurse or a parent inserts a new tube, into a child, a screen pops up and it allows us to enter the information of what size of tube we used, how many insertion attempts it took, what were the internal and external lengths of the tube, all the information you need to safely care for that patient with an NG tube down the road. And one thing we were able to do, and it will come in on, again, a future update for EPIC, is in that little checklist is going to ask, do you want the NG teaching checklist inserted into the patient chart if not already there? So it's just going to be just another way that the nurse is remembering we need to do this, get it right out there in front of us. And from there, hopefully we'll get a little bit of better completion rate. So we got 50% of the asks, so not bad. And we've kind of worked around one of them. So we're making it work for us. And hopefully all these things coming together will make a big difference. And then the very last piece that I spoke about was the completion accountability. The lack of a designated role or service to sort of flag and complete records. Our staff has, I think we're something like 75 people on our staff or more. I don't know, nurses. A huge amount of people.
About 200.
Oh my gosh, 200. Okay, I'm behind the times. That's a lot of people. So you can imagine with all these people that there's really nobody that's going to say, well, I'll take that on and make sure that everyone's all the appropriate paperwork's done. So thankfully, we just recently had a realignment, and our community discharge team coworkers, our peers, who are also nurses, they typically take care of getting all the supplies organized for when the children go home with NG tubes. And so they've recently been aligned to our unit. So now we work with the same 2 or 3 CDT folks. And so it's been amazing because it was very easy for them to step up, and they agreed quite willingly that as they get all the patients supplies ready, and they're doing all their little tick marks to make sure that they've got the muco and the tubes and the syringes. One of the things on their checklist will be to make sure that this NG teaching checklist is completed. It will be done several days at least before the patient goes home, in enough time for CDT just to flag the nurse that's caring for that patient in those last few days to say, can you please make sure that you finish filling this out? So that was great. That will definitely help us to get these filled out. So, and then the last piece, of course, we're not quite there, checking for results, because we're still trying to implement enough things to see if we're going in the right direction. So although my project and my term will be finished, I'm still hoping in early 2026 to repeat a chart audit of children that have gone home from this coming July until the end of December of 2025, just to determine, first of all, what percentage of children discharged from CHEO had completed NG teaching checklists in their electronic health record. The same question I asked at the beginning. And I also want to look at, because I get all the data from all areas, were there any other areas of CHEO that either haven't met the checklist goals, which I don't really anticipate any big change because we haven't really brought it hospital-wide. We've been focusing locally, as I mentioned, to begin with. But really, I'm also interested in seeing, has it actually spread a little bit hospital-wide? And hospital-wide, have we increased our numbers as well? And then hopefully we can celebrate our successes. And yeah, so that's kind of what I've been doing for the last year. And I'm going to hand it over to Megan.
So Allison gave a bit of an overview of the program, the purpose, the role. We heard some cool stats and some statements coming out of the work that's been done. Laura talked about the project she chose and what she discovered along the way. And I wanted to share some of what I've seen from my role as the clinical manager of inpatient medicine and what I've had the privilege of seeing and the impacts this role has had on Laura's work for the last while. And I have to admit that I don't think I fully appreciated how this initiative could be so impactful. And I certainly didn't appreciate the link between a clinical informatics champion role and leadership development and staff satisfaction. So Laura's participation in the program really started off as an idea of how, changing how we charted NG teaching for caregivers. Clearly, she was on to something. Something that was experienced in several centers throughout the country. And not just on our unit. Though throughout the clinical informatics role, I got to see Laura's shift, and Laura herself expressed a shift in her perspective and her approach to the work that she was doing. So what started off as a simple fix quickly became an explosion of ideas, and it has reached far beyond the checklist. And I saw a real shift in Laura as well. She became excited to talk about the work that she was doing and saw a new way of delivering care. And watching Laura's perspective shift and her leadership skills grow was incredible. I got to experience seeing an experienced RPN share her knowledge with others and lead the team and get them thinking about the possibilities that were out there and how we could get there. Next slide. So Laura shares her knowledge and her expertise with the team through communication. She touched briefly on this, but she's been meeting with staff. She has walked multidisciplinary teams through her project and her findings. She provides at-the-elbow support on the unit. She's led huddles with the staff. Her posters adorn the walls on the unit, reminding staff of the importance of documenting NG education and sharing information about what to look for. Her work in the clinical informatics champion role focused on improving care through the electronic health records, keeping staff informed, supporting them with documentation. Through this, she has advocated for safe and effective care with the NG teaching checklist, though this certainly, as we heard, isn't where the work has stopped. So Laura's work has informed some of our other workflows already on the unit. So as she mentioned, she's worked with our care coordinators who help patients and families transition from hospital to home, and has brought awareness and attention to the planning of discharges and what to be looking for and to flag what what to flag if it hasn't already been completed. Next slide. So Laura's years of experience and expertise as an RPN caring for infants and their families meant that she brought that perspective into the clinical informatics role, which was so important. And she had that real understanding of how to make the most of this program. So we now have other team members who are working on projects connected to the work that Laura has done. So we have another team member who is beginning a research fellowship that builds off this work. She's started looking at some of the gaps that have been identified in terms of parental readiness and the learning environment for teaching the NG teaching. And then our nurse practitioner team, they often oversee a lot of these patients that require NGs and have complex feeding needs. And they have started to think about ideas on how they can improve care for these patients and the families through offering additional support. In the inpatient medicine leadership team, we've recognized the importance of the work and have prioritized focusing on complex feeding, including NG teaching for caregivers as part of our local level action plan for the coming year. So what started off as a clinical informatics champion role and an idea about how to improve one checklist has evolved to Laura leading change and transforming how we think about care delivery and setting new priorities for our program and ideas on how to get there, and really building a success story that we now get to share with others. And all of this really started because one RPN had an idea about how to change one checklist.
I did promise everybody that I would circle back into what did I get myself into, and I actually forgot to circle back. So I just wanted to tell you about some of the things that it meant for me, and thank you for all those lovely things you said. And a lot of them I really felt myself as well. I did experience some amazing collaborations with many of the CHEO RNs. It gave me a real appreciation for what the nurse practitioners are doing and how we can work with them on the local level again. Our physicians, the IS department, geez, they're so smart when it comes, like, they're just so smart, the IS department. And the occupational therapists, they've all kind of come together to work on this project. And it's been really interesting getting to make those neat connections. What else did I get myself into? I had opportunities to make some real change for our patients and their families, as Megan was just explaining. I've also had opportunities to overcome a few of my fears of public speaking, and this is very outside the box for an introvert like myself. So that's been pretty neat. And I've also had opportunities to learn so much in terms of technology, because while the rest of the world was in COVID, learning all the technology and how to do exactly what we're doing now, virtual presentations, I was at the bedside. I missed all that. So I've had a huge opportunity to learn how to connect virtually and all the other neat little tools that come along with that. It gave me a real appreciation for how deep Epic is and how deep our electronic health records can be. There's so many layers that I didn't even realize were in there. And maybe it kind of opened my eyes of maybe we could do this too then. Like things I don't even know that we can do, they're already in there. So it gave me an appreciation for how deep things are, and some things can be fixed real easy and some we can't make changes to quite so easily. And I also have a bit of a newfound appreciation for my job again on the floor. I really liked being able to take what I was doing at the bedside and think about it in a different way, use a different part of my brain, something that it kind of hasn't worked quite the same way in many, many years. And while I've always loved bedside nursing, it was really neat to be able to make a change in a different way and impact so many families. And as I'm coming to the end of my career, it's neat to think that this might, that it'll live on, and I'm making some changes that will help kids for the long term. And I think most importantly, I think it was really great for me to be able to show some of the other people, some of my colleagues, how much the RPNs can contribute to leadership roles and projects that can make big impacts on our hospital. We've been doing a lot of that. We are in our hospital, our RPNs have really worked to a full scope. But it's been neat to challenge people to sort of look at what I'm doing in more of a leadership role as opposed to the RPN at the bedside. And that's been really neat too. And people would say, oh, I didn't know you were an RPN. And, and it's just really neat for them to start thinking about RPNs in a different way. And I really liked that. It was very empowering that way. So.
Thank you so much, Laura,
Yeah.
for sharing your presentation, and thank you for having us. And we're open to any questions that you guys have.
That's really excellent work, Laura. What a shining example of applying knowledge and developing leadership and using innovation to inspire you at this stage of your career as well. I mean, it's wonderful, really, and the leadership at CHEO for really leveraging the expertise in this RPN. So congratulations to all of you. Excellent work. So we certainly do have time for questions. I will say the comments are just accolades to you, Laura, on your work. The one comment Tammy says here, love that my frustration was greater than the sum of my fears. That comment that you made at the beginning of the presentation, just lovely, and driving in with 2 feet to make change. I really echo that. Just wonderful work, Laura. Jay says here that he's been supporting Epic's launch in UHN and SHN and very comfortable with Epic's functionalities. And if you are looking for any help, he's willing and happy to connect. Lots of way to go, Laura. Amazing work. So very helpful. Great job. So we'll see if we've got any questions here in the chat. Great work. Nicole says, I absolutely love hearing about the structure of this program and appreciate hearing the process in applying this. Amazing presentation, Linda, and thank you for sharing such an in-depth analysis. Thank you to all for presenting and sharing the topic. Our organization is looking at starting a similar program, and this is a great blueprint. I also love hearing the impact that Laura's work had on her professionally and to her fellow coworkers. Such an inspiring story. Thank you for sharing. This has been really lovely. So we do have some time for some questions. I had a question myself about the actual education piece and the use of the technology. And I'm wondering, was the education happening and the technology not being used, or was it a combination? Were there moments where the education was happening and not being followed up with the technology? I guess that's a question I have for you there.
Good question. The teaching's being done. And it was being documented in many different places in the chart, but not the place we wanted it. We have a thing at the end of our shift where we write a little end of shift summary from the nurses, sort of the calls, the highlights of the shift and things that need following up on. And a lot of it was going in there. There'd be a comment of, I taught David how to flush the NG tube today. But unfortunately, there's no way of tying all those little pieces into one quick glance. Has David finished all of his teaching? Right? We didn't know what David needed to do. So when you went through, there was many different spots, and there were a few other places within Epic that people would do their charting, mostly for a lack of not knowing how to do it in the correct place. But yes, and we spend a lot of time with our families before they go home. A lot of our families that go home with NG tubes are in a situation where they're in one room with 2 other patients, and often there's a nurse in that room. So we really get a feel for whether the families know what they're doing or not. But yes, so definitely education was there, just not documented in the right place.
And maybe if I could add and answer the question from a different perspective, seeing a comment in the chat that someone might know that the checklist was there, but it hasn't really been followed up on in a few years. We see that with our upgrades too, where we might send out a memo to say, you know, we just did our spring upgrade, here's some new functionality, and that goes out in a newsletter or a memo, but then similarly, the resources aren't there to follow up on that and make sure that people apply and understand what some of those improvements are. And so in the other half of the informatics champion role, our champions were out at the bedside helping people with that at the elbow support of, you know, when we had our spring upgrade and we sent out the memos of what was coming, they would really go in and show people like, hey, do you have 5 minutes? Can I sit down and show you all of the new things that are coming? Which really improved the adoption of some of those efficiency features that otherwise, you know, people just don't have the time to go through their inbox and look at a tip sheet and open up Epic and compare the two. So really being able to help people so that we can all be more efficient. The champions got the additional Epic training, but then, you know, how they go out and spread and disseminate that was also incredibly helpful and had big impact on the satisfaction of nurses not in the program. So despite not being champions, we hope that we left many team members with some efficiency tricks and improvements.
Well, again, I want to thank each one of you for presenting this afternoon and giving your time and join this Nursing Week. Laura, thank you very much for your work there at CHEO and being such an outstanding representation of leadership within an RPN. And with that, I've got a couple of announcements.